comes to us from India. He's a senior consultant and international faculty of interventional spine at the Pain Super Specialty Hospital in the Max Super Specialty Hospital in New Delhi and Sri Balaji Action Medical Institute and Cancer Hospital, New Delhi. He's the director of Spine and Pain Clinics there. He's a FIPP. He also has CIPS, which is also awarded by the World Institute of Pain. He also has a degree as a FIMSA in Ajman. He has presented nationally and internationally, and he's going to present his techniques on advanced innovative pain interventions in difficult spine cases. Welcome, Dr. Jain.
Thank you so much. Good job. Yeah, I know it's a little high. So it takes you high. Good morning, friends. First of all, I must thank you, Dr. Professor Devan and NYNJ team for inviting me to deliver my talk. Some of my interventions which I can share with you in difficult spine cases which are otherwise very difficult to manage. I stated go to the talk because this is longer and I might run through a few slides if I fall short of time. So please be. There's no conflict of interest except that I really want to heal my patients in and out. And these are the patients who have been suffering. You're trying to do everything with them, the conservative management, and sometimes even the interventions, and maybe lately even the surgeries can't help these patients. So, and you see this patient who has been operated, there is 3 surgeries been done, open surgery been done, endodiscectomy and myodiscectomy, and still is suffering with the list and the limp in the leg. And sometime, there's another post-surgical patient, and he's begging for the death. And look at the agony of the face of the patient as well as this, so matching with the sculpture. And even in spite of all this painkillers which you can day in, day out, they may line them to a dialysis unit. So, but with the right intervention, you can really bring them back to life. The same patient, you look at the changes, you see at the face, and look at the life, you look at the eyes of the patient, and it's bring back to life. Yes, needle can do magic, better than knife inserts in some patients. And we really have to understand the usefulness of the interventions. And interventional pain is growing bigger day by day, and it's really rebounding again because there's so many advancement going on, like neuromodulation. You see all this conference. It's a very upscale conference, by the way, with so many practical talks. And you can see all these things, doable things, by the way, not just theory, all practical things. And yes, and in spite of patient has been operated and patient suffering with the pain, you can still help. We are always a friend to the patient, be it surgery or primarily come to us. Now, we have taken lead from all these stalwarts, who are all there, and they have brought the pain to a different level altogether, and all these conferences are still part of this whole process. And these are my inspirations, by the way, and taking cue for them, I'm trying to do my bit. Now, this is, we keep saying, patients with low back pain, we know it's a non-specific number of times say, and sometimes you can't really diagnose it, so it's a diagnostic dilemma. So a very small cue, but very helpful. I take the patient to the CM room, ask the patient to put a finger on the pain, and just take a shot. And once the shot is taken, you can really zero down, or you can narrow down on the diagnosis, like this is a Bartolodi syndrome with this patient, and some other patient can be a Riptip syndrome, Millie-Crest syndrome, or maybe Clunian-Love syndrome. And once you have this thing, you do an LA test, and after LA test is positive, you can do an RF or chemical neurolysis, and these patients can be really helped. I've seen a good number of patients who come to me post-surgically, and they have been operated because want of the relief of pain, because this was not diagnosed in time, so patients done a disc procedure, which may be evidently present because it is coexisting some time. And another young boy, just 2 months before marriage, he had a big disc coming in, foraminal disc in there, and he's having a pain in the arm, but he's not worried about the arm pain. It is just 2 months before marriage. He had a drooling hand. If you put a hand on the paper gets wet, and that was a bigger worry because it's very social embarrassing for him. I did a sympathectomy on this patient first, and then later on went ahead with the other side after a week or so, and then went ahead with the disc procedure. And I met this patient. This is 2012, by the way. I met this patient recent past with a baby in his lap. So you can make those changes happen in those patients. And this is what I used to do in those times. I used to do biocoplasty with the radiofrequency. Now lately I'm doing a further procedure on disc and other procedures. But just to share with you, now ultrasound is coming in a very big way. One slide, one of my friends, and we have to combo these things. We have fluoro and ultrasound combined, that's the future, and we should adapt as soon as possible because it really gives kind of safety to the patient and procedural success also. But if you look at this slide, and this in the neck, there's so much of tubes and viscera is there, so you really have to be very careful, because you won't fluoro, you just see the bones. And that's what I'm doing, disc-FX. If there's a bigger disc which is impinging there, I just put my disc-FX like in lumbar area, take my fragment out in a fragmentectomy, targeted, fluoro-guided. And once the fragment is out, I decompress and my nerve is taken care of. And thereafter, I just put my RF needle in there and do my annuloplasty. With each disc procedure, if there's annular pain is there, better do annuloplasty or something annular denervation, because otherwise patient keep coming with the neck pain or the back pain. It's imperative on our part. Well, an Iron Man, but with a bad back. Yes, happens day in day out. And that's why surgery is getting defamed by each year, and we are going more and more like least invasive or intervention. You so much of a growth of MI is coming in. Same reason. Because we had a fibrosis because of this big surgery being done, and we have been trying to break up with the fibrosis. Even this good old Rax catheter, which helped hundreds and thousands of patients, couldn't help because it bends. Even the epiduroscope, you look at I'm trying to put an epiduroscope, it is bending therein, and look at the epiduroscope, it doesn't give in. These are very hard fibrosis, the patient is operated a few times, and that's where I evolved a technique, and I want to share with the gathering. That looking acute, look at this balloon which is doing valvoplasties, angioplasties, CVD dilatation or ureteric dilatation, and when it works everywhere, why can't it work in the epidural space? So I did epidural foramen neuroplasty in many patients. I do it for neuroplasty reasons and even in combo with the kyphoplasty. I do transfemoral in the area, and it's a safer triangle, everybody knows, and we do disc procedures through this triangle. And obviously the path is we going posterior to anterior, we have to land in the anteroperable space. This anteroperable space I combo sometime with the vertebral augmentation. I'll show a few more slides after this, and this is how I'm doing it. It's a wide bore blunt tip needle. We put inside over the guide wire. I put the catheter, balloon tip catheter in there, and then we can inflate the catheter, guide wire in place, and at the end of the procedure I can medicate, take the guide wire out and medicate the area, just like an epidural catheter thereafter. Yes, I can take it against the posterior cortex, vertebral anterior epidural space. You can beautifully see this. And this is put over the guide wire, so you see it is run over the guide wire. You can take it carefully, caudally, and you can really put it behind the disc if there's a disco-radicular conflict which is bothering the patient. Yes, it can be put through the caudal route, transfemoral I just showed you, and you can up and down. I very often do it through S1 foramina. There is a reason, because L5 S1 disc is the one which is quite often the conflict, which is the problem with the patient L4-5, and it can be managed through the S1 foramina better than the caudal route. And obviously transfemoral I sometimes combo with the endoscope. I put in an endoscope. If I really need to be more assured, I put in a balloon, check my balloon, and there's no filling defect on the part of the balloon. I've comboed it with the cervical procedure in some patients only, whom I think really needs help and they are not surgical, or why should one do a surgery if you can manage these least invasive procedures? It's a very clear word. And this is what we just take it up there. You can see the catheter is going up there, and this is again the C2. You see the dance in there, and this is the catheter in there. You can inflate the catheter, do soft tissue dilatation, not for the bony stenosis, and then you can put your medication. Because if you put medication, otherwise medication tends to go to the normal area instead of the stenose area, and obviously is no benefit to the patient. I presented this paper in the World Congress of Spine Surgeons in Jeju Island, Korea 2016, epidural balloon neuroplasty and foraminoplasty and innovation. And I'm happy to share this gathering with a little fewer advances. Now with the endoscope also, sometime when you're trying to take the fragment out, Dr. Datta gave a beautiful talk, and with so much advances going on, let's add some value. And what I see is if the fragment is run off, is gone out of the place, and I just take the balloon in there, take the fragment in place, and just like taking cue from the balloon stone retrievals, and bring the fragment to the face and just take the fragment out. And you can just have a look at it, the fragments are taken care of. There's a balloon which I just put through the scope and take the fragment out if fragment is run off of the out to my side. And same can you manage with the scope through scope, which is a flexible scope, which is 180 degree, kyphaloid caudal, and you can direct it inside and have a look inside. You can peep in of the area in the 1550. And once you do, it's not just a diagnostic. You have to make it therapeutic, like bronchoscopy. We have forceps, we have tri-prongs, and we have baskets also. You can put basket in there and fish out the fragment if you need to, like doing stuff for the stones. So why not? Means as simple. And with this all advent, we can really take big fragments out, like interventional we saw some big fragments coming out, because you are not worried, you got so much in your hand, you're going to war with the armamentarium with you, and you're not likely to fail. And like the big disc fragment, and you look at the big disc fragment, which is got a red head, which is the epidural reaction. This is the body of the fragment, this is the neck of the fragment, which is entrapped in the annular ring, and this is the intradiscal portion with the end plate. I showed it to Anthony Young, and he was very happy to look at this fragment, who was father of the transplanar endoscopy for that matter. Yeah. Yes, with the void being created, we have to fill it with the fibrin plug. Yes, but must do annuloplasty, as I said it earlier. But there may be situations. You're looking at the free flapping root in dura, you're very happy. That's what you need to see at the end of the procedure, and adequacy of the decompression. But there are times when there is a big annular rent, and this annular rent is really worrying because there is going to be a recurrence very often in these patients unless the annular seals in time. And for this reason, I sometimes, because of fear of avoiding the recurrence, I put in we do a mesh annuloplasty laparoscopically. So why can't we do it? So I have absorbable mesh, I put inside across the annular tear which is there, and I've got absorbable tuckers also. I tuck the fragment in place so it doesn't move out till it gets absorbed in 3-4 months time by the time the healing has occurred. Now, this is the topic very close to my heart, and mainly I came for this to present this. This is the doing a vertebroplasty possible in those difficult patients which is otherwise nearly impossible. And one small cue is that PMS cement doesn't look so well. So you need to see a cement which looks nice. And what I do for that is when I make my cement in the cold cement bowl, I just put in a Omnipec dye at the end of the mixing and really make the cement look black. And I'm doing it the last 15 years. I've got sample preserved from the first patient of mine, and they're as hard as they were 15 years back. And you don't lose on the strength, and the cement looks all black in there. You can see even the particular nail which I left back in some patients. So you're less likely to leak the cement. That is a big worry for this procedure. Another improvisation which I do is instead of using this more articulated or more costly devices, I just use 2 ml of the Lulox syringes or 1 ml Lulox syringes and inject my cement in there, because in our part of the world with a poor patient, you got to help them and you got to cure them, and this is our duty too. And it really works good, by the way, if you have a control hand, which we are doing day in, day out. This patient had a single level fracture. In 2 months, 18 days, he had 6 level fractures. In 2 months, 18 days, and I had to, because it was very painful and it's lying in the bed. I did 6 level in one go, presented in Miami World Congress 2010, and this was 12, by the way. And there is no leakage of the cement, and there is no flexion, sagittal deformity, and patient's happy. But when you're doing all this multiple level cementing, you must make it sure that you don't try to go for one side, because there is going to be a needle fight, and you don't want to, those two bulls fighting when you're trying to do your cementing in. So you try to do alternate side if possible. Yes, there are patients who have osteoporotic fractures. There is retropulsion, there is a fluid liquid collection. You can see in here liquid sign, and then the cord is already getting compromised, and they are infirm. Either they have comorbidities which doesn't allow, the surgeon doesn't want, the patient doesn't want a procedure or surgery for that matter. And there's the malignant patient with a terminal end of life care, and they are already compressing the cord. You have to help them. You have to give them quality of life, even if end of life. The last 2-3 months left, still you don't want them to be in pain, dying in pain every day. So that's what I do is I put my balloon in the antiepidural space, which I showed you earlier, and I do my vertebral augmentation. I splint my posterior cortex, and that is how I do it. Look at this. This is the balloon which is inflating, and you elevate the end plates, and you have vertebral augmentation, anterior column reconstruction you can call it, and then you have a balloon which really shows up. The beauty of this balloon is that it really saves the cord with the 6 mm, and then it really shows up if there's any fragment which is getting pushed, because there can be loose fragments sometime, and then you can really kind of catch hold of those fragments and keep it in place. By the time void is created, and after the void, you're doing a cementing. Now this is cement in place, the balloon is still intact and in place, and you're going to remove the 6 mm balloon, 6 cm in length, which takes care of 1 or 2 segments, and you take it out, and cord is happy, patient is happy, and you're happy. At the end of the procedure, you do a myelogram, and it really shows up, because you want to really authenticate your work and have a good night's sleep too. So it's so vital. And that allows me to do these dirty fractures. There's a burst fracture in a middle-aged lady with a polytrauma setting, and you have to do these procedures. You can't say, okay, go for surgery. And I again say, why go for surgery? That's my word. So this is what I can cement in there. You see a retropulse fragment in there, and there's a loose fragment which is there, which doesn't allow doing kyphoplasty in such situations. But with the advent of this epidural safety balloon, I could manage to do cementing. Even the retropulse fragment is taken care, because it stucks to it's like putting a brick over the mortar. It's like this. Another such patient with a vertebral planner. I'm doing many vertebral planners now. There's no bone in here. Look at, there's no bone. These are the two kissing discs in there, and the cord is already getting compressed. Patient needs some help. You got to do something about it. And this is what I'm trying to do. The same procedure improvisation I'm able to manage. This is 86-age lady, and she is really dying in pain, and really gave her quality of life for the next few years, which she had to live. So this is what it is. The empty bone, you see vertebral reconstruction. There's no bone in here, and the vertebral load-bearing structure is created, and there is a flexion is kind of sagittal deformity is corrected. So that corrects the posterior pain, which sometimes happens because of the flexion. These patients have start having new pain. Now you can count your blessings. With the good work done, you really want to help these patients. By the way, they're old, informed patients, and these days when the life is so busy with everybody, you miss. It's difficult to put all your life over. The one patient suffering is not just the patient; it's the whole family suffers. And these old patients, you want to help them all relatives will want to help them. But if doctors can't help it, who can help? So it becomes all the more our duty that we help these patients to help the families together and society in totality. And that is what it is. You can count your blessings, and with the good work done, and they are back to life, So otherwise they are left to bed to die. It's not fair deal. And understand our own families and we ourselves, what we really want at the end of life. So this is sometime when you have a one-level lesion like a fracture or a disc lesion, and what happens is sometimes patient develops a new lesion. Now these two together augment problem for the patient. So what we have to do is I cannot think of doing just one disc procedure and leave the fracture, or fracture or leave this disc. So might have to combo these procedures. So lately I'm trying to do an endo procedure or disc procedure as well as the vertebral augmentation. But then you have to be proficient in both. Only then you try both. You do one or leave the other for the other person. But yes, the both can be doable. We can be comboed. And yes, in one go, one time, you can relieve. Yes, it is doable. Armamentarium, I find it an easy procedure for me. But yes, I want to caution people, learn it well, and it becomes really easy. Less, with all these difficult procedures, with your improvisations, you can make this procedure work in these difficult patients which I showed you. Multi-levels, there's a vertebral compression, and there is a balloon neuroplasty which is there, or vertebral plana or burst fracture. Yes, we can do it. We can do it safely. We can do it effectively and as a part of duty. Now, this is the post-surgical syndrome. Just by the way, this patient had 6 or 7 open surgeries, another 7 or 8 of the interventions, still in pain because the root is getting in pain on the implant. I asked the implant to go away, but neither surgeon wanted more surgery nor patient. There is a time of fatigue on part of the patient as well as surgeon. They don't go to any further, but patient is suffering. You got to help these patients. So spinal cord stimulator comes in a big way, and this is, I do 2 staggered leads, octo leads in place. And this slide is for the reason that I'm trying to show that I do the ultrasound of the pocket, the implant pocket, just to see if there is any collection, hematoma, or if there is anything which really is worrying, which needs to be done. So it should be done right there and then. Then waiting for infection to come, and then it spoils the whole game. And you can always look at the leads also, lead positioning with the ultrasound. It really helps in these patients. Yes, you want thumbs up from the patient, and you really, this is the, you want a happy, fully functional patient, and that brings the happy doctor too. And that's what you're trying to do with these patients, and trying to help these patients as much you can. Obviously, it is getting important from day one that we do all this, and definitely. Now, this is what I'm trying to bring this slide, especially for the reason the only explorers reach the new shows, others just follow. There are many leaders around, and this lead is for them. Now, all these people have spent their lifetime, decades together, to kind of bring the pain specialty to this height and taking it further on. They're still tirelessly working further on. It becomes our duty now to take this shift further on and see where all we can put it to the newer heights. And definitely there have been challenges in last few years with the interventional pain management, and Dr. Datta just said a minute back, and there are some issues and all. Let us prove ourselves. Let us do good work. And the rest, I think probably world will prove ourselves. It is primarily the patient who needs our help. That's more important than anything else. So I must thank all my leaders here, and they have really given us lead and to take us to further. And this is one really important lesson from them is these all teachers, and they say they've been saying teaching is the best learning. Before you start teaching others, you have to learn yourself first. Only then you can impart knowledge to others. So it is important, and teacher is the best learner, best student, and most hardworking student for the matter. So I do these workshops in my place, and that is making me do more and more, and gives me more challenge. More you take a challenge, better off you are, and that's what it is. And pain relief is a human right. We all know it. This World Congress, UN, WHO, everybody is saying it. And it's our duty to deliver it. That's to be remembered. Just a word is not enough. It brings a duty along with that. And as we are not doing it for our generation, we are doing it for our future generations as a moral obligation and medical obligation on our part. And I must thank all my friends and calling me here to share my work. I could present only a few slides because of the paucity of time and really running short of time. So thank you so much, my friends. If there are any questions, I'll be more than happy to answer during the whole conference. I'm around. So thank you so much, my friends. Thank you.